Dear colleagues, as we unfortunately had to cancel this year's World Congress in Montreal, we thought it would be a good idea to at least share some highlights from the virtual Congress that took place in February. Before the video starts, I would like to announce that the 2022 World Congress in Taipei, Taiwan will take place from June 9th to the 12th. I look forward to seeing you there in person, and now please enjoy the video. Oh, and don't forget to subscribe to our YouTube channel below for free so you can watch more videos in the next weeks. Thank you.
Good afternoon, everyone. I'm Chenda Li from Taipei Veterans General Hospital, Taiwan. It's my real honor to be invited and to present here by CIMP and, of course, Professor Hashimoto. My topic today is antidepressant effect and mechanisms of prefrontal theta-burst stimulation, TBS. It's a new form of rTMS. And I will also talk about a ketamine-responsive animal model of SSRI-resistant depression. Okay, talking about treatment of depression, SSRI is one of the first-line antidepressant drugs. However, not every patient responds to it. If you look at the results from the renowned STAR-D study, only 37% remitted after the first-line SSRI, only 37%. And the prevalence of treatment-resistant depression, that is non-remission to several antidepressant treatments, could be as high as 33%. In addition to low-dose ketamine, we still have several different types of brain stimulations that could be used to treat TRD. For example, we have deep brain stimulation by implanting electrodes in your brain to treat depression. We also have ECT by inducing convulsion, and rTMS TBS, today's main topic. They belong to the non-invasive category, and both of them are approved by FDA to treat medication-resistant depression. And not only being approved by FDA, the latest treatment guideline, for example, here I show you the CAMET 2016 guideline. rTMS is recommended as the first-line choice for patients who fail to respond to at least one antidepressant treatment. ECT was the first, but now it is the second. And the standard rTMS protocol is 10 Hz at left dorsolateral prefrontal cortex. And here, TBS is also recommended, and it's the first time to be included in the treatment guideline. So what is TBS? Actually, it's a pattern-specific form of rTMS. And if you look at the rTMS protocol here, you could see rTMS use regular stimulation frequency, like a low frequency, less than 1 Hz, high frequency, more than 5 Hz. TBS use a specific pattern of stimulation. And the basic elements of TBS is the free pulse burst at 50 Hz, given every 200 milliseconds. That is in theta range, so we call it Theta-burst stimulation. And when applied continuously, we call it CTBS. But when there is an interruption between trance, it's ITBS. And this finding is pretty compatible with a paper published in Lancet 2018. The investigators compare ITBS and 10 Hz rTMS and found these two have similar effect in decreasing depressive symptoms for a treatment period of 6 weeks. Now the question is why it is effective. The underlying mechanisms remain elusive. So to answer this question, together with Professor Lin from National Yangming University, we developed a TRD model by severe food shock trauma. We use 3, 6, and 10 tongue shock pairings to mimic mild, moderate, and severe trauma. And we taste a 4-swim test, SPT, food intake, TST, as a measure of depression. And we found all rats presented with freezing behaviors, but only the high traumatic group, the 10 pairing group, presented with depressive behaviors. And we sacrificed them and found that only in the high traumatic group, we have decreased phosphorization in the prefrontal cortex, a phenomenon pretty similar to that observed in human trials of depression. So this is my conclusion slide. The points are TRD is very common in depression and associated with decreased prefrontal function. And low-dose ketamine could be able to treat depression rapidly by increasing prefrontal activity. And we also demonstrate ITBS is an effective treatment option for depression. And using the SSRI-resistant TRD model we proposed, we found ITBS increases frontal synapses and normalized BDNF-dependent LTP and LTD. So a lot of people to thank for, and of course your attention and your time.
Hello everyone, I'm KET from Anhui Medical University. Today we will show this slide. My slide title is Major Depressive Disorder, Bone and Ketamine. Major depressive disorder are the most common mood disorder. This study shows the data from USA. This slide shows data from China, the prevalence of MDD in China. Lifetime prevalence is 3.4%, and 12 months prevalence of MDD prevalence is 2.1%. Now, more than 20 million patients, MDD patients in China. So MDD is very popular in China. If you got MDD, most of the time you need to use a drug. Most of the doctors will choose SSR to treat the MDD patients. This slide shows the effects of SSR in children with MDD. SSR will increase the BMD of MDD patients. These patients are children. This slide shows the effect of SSR in older women with MDD. Use of SSR but not TCS is associated with an increased rate of bone loss, as the hip is cause of older women. SSR also decreased the BMD of mice with MDD. this article published in Nature Medicine. Ketamine, also known as ketamine, is a racemic mixture which contains equal parts of ketamine and S-ketamine. The second question, we want to know which is better to the bone formation, ketamine or S-ketamine. So we select the CSDS animal model. Social diffuser stress model has been widely used as an animal model of depression. We examine the effects of S-ketamine and ketamine in the CSDS model. In this model, S-ketamine and ketamine was injected into mice. And then we performed the behavior tests such as sexual preference test, tail suspension test, first swimming test. We also collected plasma of mice that made the bone biomarkers. This slide shows the data at 6 days and 7 days after a single injection. As you can see, ketamine was more potent than S-ketamine, the SPT, TST, and FST test. This data suggests that ketamine's antidepressant effects were more potent than S-ketamine in this model. That's the summary. Patients with MDD have a clinical loss of trabecular bone mineral density at the hip and spine. Use of SSRI is associated with an increased rate of bone loss at the hip in MDD patients, and ketamine is bad for the bone formation. Ketamine, but not S-ketamine or HK, is bad for the bone formation. And we also find anti-rancor attenuated increased plasma levels of rancor in CSDS stable mice. Anti-rancor improved the decreased ratio of OPG rancor in the plasma of CSDS stable mice. Anti-rancor attenuated decreased BMD in CSDS stable mice. Anti-mouse rancor antibody could produce rapid antidepressant effect in CSDS model. Next is our group in Chiba University. The right is the new group of my Medical University. Thank you very much.